Welcome to Diabetes Health Matters, which is a conversation with Dr Raymond Ladele, who is a GP and GP with special interest in diabetes and a Diabetes UK clinical champion. We're going to be talking about diabetes and men's health. And I'm very delighted to welcome Ray. Welcome.
Thank you so much, Joan. It's a pleasure to be here.
So we're going to be talking about diabetes and men's health. So let's start at the beginning. Ray, why would you think there might be some challenges in diagnosing men with diabetes? Why do you think that might be the case?
Thank you for that, Joan. I think there are quite a number of reasons why there might be issues in the diagnosis. First and foremost, the common symptom of diabetes, which are usually what we call lower urinary tract symptoms, which just means symptoms in passing urine, is commonly associated with, shall I say, elderly men's problem. So, of course, we know about the prostate. The prostate gland is a organ that sits just behind the bladder, and at some point, most of the time, as it gets bigger, you might actually start to have what we call urinary frequency, which is meaning you're going to use the toilet more often than you should, or that you usually have. But this can actually be a sign of diabetes. And many men might just think, oh, it's just my prostate getting larger, and they might not actually seek help to otherwise find out that, oh, this is actually something else rather than diabetes. Another common symptom of diabetes is fatigue, just being tired all the time. Most men, as they are, take a lot of responsibilities trying to put food on the table and work very long hours. And they just think it's all associated with the job of just being the man of the house and making sure everyone's happy and more or less walking, around the clock, trying to get everyone in the household, comfortable.
So, I mean, Ray, we love to use the word vintage here as opposed to older. So men of a certain vintage might mistake those symptoms of urinary frequency. So getting up at night more frequently to pass urine. They might suspect that they've got prostate issues, but they might not suspect that they're developing possibly something like type 2 diabetes. And fatigue, we can all sort of rationalise that. We think it's, other things that can be causing that fatigue, because it can be so insidious as a symptom. So those two things can make it quite a challenge on the part of the person themselves, but also for a healthcare professional sometimes to make sure that they diagnose men as in the same way that we would diagnose any person. So what other things, specific things, might men get as a symptom of diabetes?
Yes, some other symptoms could be erectile dysfunction. So many men do not actually link erectile dysfunction to diabetes, but this could actually be a very early sign of having diabetes. So that is one thing that we as healthcare professionals, and I for one, always makes it as one of my discussion points about trying to bridge that topic and normalizing it, as there is a lot of stigma around talking about erectile dysfunction in men.
I think it's so important, as you said, to normalise it, because this is something that can be a presenting symptom. So it can be the first symptom that somebody has when they're developing, let's say, type 2 diabetes. But also along that journey living with diabetes, type 1 or type 2, it can be a symptom that can occur. So normalising it, I think, is really, really important.
That's very, very correct, Joan.
what would you say, Ray, are the differences, if you feel there are any differences, in the way that we would advise how to live healthily with diabetes if you're a man compared to a woman?
Okay, so I think we healthcare professionals, um, it's quite obvious that the common um, people who come to our clinics are heavily on the female side compared to the males, and this could be due to a myriad of reasons. But men tend not to present, maybe because of work, maybe because they're just feeling like, oh, I'll just get on with it, I'll just suck it up. It's nothing major. Or even in terms of, having their reviews. People living in diabetes in the UK are all they're all required to have what we call key care processes, and there are 9 of them. Most of the time, we it's quite challenging for us to get the men into these review clinics to check all their key care processes, which include checking things like their weights, talking about cigarette smoking, their blood pressure, and all that. So I think we don't tend to have that space to have these conversations with men, and even seeing that, oh, are they actually taking their medications? Because even requesting their medications, we find out it can be a bit of a challenge, maybe because of time pressures. They're not even requesting their medications in time. And aside medications, even a lot of all the lifestyle programs that are out there, even at the time of diagnosis, like the structural educational programs such as Desmond, which is one of the most commonly used ones in the UK. The timing of these programs and the hours usually are unfavorable for men. And you find that most of them have the highest rates of do not attend, which we call DNAs. And it's a challenge all over. And in my region, we have been looking for ways to try and see how we could best provide these structural educational programs that will suit the lifestyle of men.
Absolutely. And Ray, in terms of the tips that you and your colleagues have found that may work with all these challenges, because you've mentioned a number of challenges, the time to be able to take time off work to attend for an annual review, to remember to request the medication so that you can take the medication on a regular basis, the programs which are available which may not suit men. Have you any tips, any advice that you can share with us about how you've addressed those challenges?
Yes, we have tried to address this in a number of ways. One of the things we have found out is that men are quite more open to remote consultations, so telephone consultations. So actually giving them that option that, look, you can have some of these reviews as a telephone consultation, so we can discuss some of these key care processes or the issues around their management. Another thing we tend to do is we have extended access appointments, which are usually done in the evenings after work period or on a Saturday morning. So that usually usually it's a time where maybe they're not busy they're not busy with work, and they could then attend these clinics, and then we could have a good discussion about how it is important for them to adhere or take their medications and talk about things that concern them about the diabetes that they're living with, and even things about measurements, because there is, most of the time we tend to just measure the weight, of our patients living with diabetes, this underrepresents the risks in men, because most men have what we call visceral fat as compared to subcutaneous fat, which is the one you could see on the outside. And the weight underestimates it. So we know the big link between obesity and diabetes, and we know that if you actually check your weight circumference, it is much more representing the risk that a person either already living with diabetes has or at risk of diabetes. So one of the things we tend to do, or I tend to do in my clinic, is actually measure their weight circumference, because the weight circumference, especially in men, because men have what we call an apple type of obesity, where they have a lot of more of the fat is distributed inside, around the pancreas, around the liver. So you get there's a bit of central type of weight that is visible, but it still underrepresents their risk. But the waste management measurement actually tells us more.
Thanks very much for giving all of those tips, making it more accessible in terms of the time, making it more accessible in terms of the mode of delivery, so online or the telephone might actually be better, and then using things like the waist circumference to estimate where somebody's at in terms of a healthy cardiovascular risk, if I can call it that, or a not so healthy cardiovascular risk. So thanks very much for that. So with regards to the man himself, and the quite frequent setup, I can't call it normal, but the quite frequent setup whereby somebody else may be doing the cooking, somebody else may be doing the shopping. How do we tackle that? How do we address that challenge?
Yeah, that is a big challenge, Joanne, as you rightly mentioned, especially in African households. I would say, the common, as you said, the not normal. The common thing is that the woman in the house tends to be the one who does the grocery and sets and does the cooking. Now, it's not that we need to, from my own point of view, change that dynamics, but I think it's very important that whoever is responsible for that aspect, and I will still encourage men to get involved in some of these things, but whoever is actually responsible for that is aware and is well informed about what the individual or the man in the house should avoid and what is best for him to eat. Because it's I always have a conversation with patients in my clinic that there isn't such a diabetic diet. What is important is it should be a well balanced diet, and there is it's very important that the portion sizes is the predominant issue in your plate. So what portion of your carbohydrates compared to the proteins is highest? The person responsible for the cooking or the grocery should be aware that if you are living with diabetes, your carbs has to be the lowest portion on the plate. Men should actually get more engaged in aspects of the kitchen if they can. I know it can. It's not for everybody. I'm guilty myself, but I make it as a duty that on Sundays no one's touching the kitchen except me. So if I don't do it at all, I know once a week I get to mess up the kitchen. But so I will encourage men to get involved in that. But more importantly, whoever's important has to be aware of what is best that the man can eat if he's already living with diabetes. And there are loads of materials out there. Diabetes Africa has done loads of materials about diets in the context of African type diets, and there's so many things. I always tend to point my patients to different reading or online resources about this.
And I suppose one of the tips then you're saying is get the other person, whoever is in the house and is doing the shopping, is doing the cooking, involved. So it may be that within the consultation that person comes along if the patient themselves give permission for that to happen. But that can be a good way to address this challenge, as you've highlighted. And I'm glad to hear that you're encouraging men to get into the kitchen and cook. Another wonderful tip. So let's talk about, I think, following on from this, the healthy living programs, whether you're trying to prevent type 2 diabetes, whether you're giving information, as you mentioned, the structured education, so-called self-management programs that somebody living with diabetes is encouraged to go on. Sometimes I think men who attend this might feel this is just focused on women. There may be a preponderance of women there attending, and men may feel that they don't belong. What's your comments? What's your views on that?
First and foremost, the timing of these programs and the way that these programs are being offered should have men in mind, because you will find that most of the time these programs are done maybe right in the middle of working hours, and most of them are actually face-to-face type programs. And this is actually a challenge for men, as I earlier said. And if you go there as a man and you take some time off work and you then see that, as you rightly said, Joan, it's maybe 90% women and 10% men in the room, you then start to think, am I supposed to be here? And across the whole patch in my area and even all over the UK, a lot of these programs have a high rate of low attendance, do not attend, they don't attend face-to-face programs. But even now, we have adapted these programs a bit to actually offer remote programs in such a way that they could be online like this and have this discussion about things surrounding diabetes. But the hours sometimes is an issue for most men, because I've spoken to most men and say, look, I can't sit down for an hour or 2 hours. So it's kind of looking for how we could maybe make these programs more bite-sized, smaller, time frames, maybe 30 minutes, and try and make them as concise as possible, and possibly even just make some that are specific to men, and they might actually be able to come out more and discuss some of the challenges that is difficult to talk about, like erectile dysfunction, as we spoke about. I'll tell you a story. My elder brother, who lives in the UK but does a lot of business in Nigeria, and he's about that age, 50 plus, and he was at a gathering with some of men. I think it was more like a social gathering, and they were just talking, and one of them just got bold enough to talk about issues in the bedroom, and then all of them looked at themselves, and they're all at that kind of same age group, and all of them like, you too, me too, and all of them, it then looked like they all had this problem but never spoke about it. And I have actually had to help some of these gentlemen in addressing some of these issues because one person was able to talk about it, and then everybody felt comfortable to talk about it, because it is, at some point in time, for most men, this might be an issue, because most of them have actually ignored the cardiovascular risks they are facing. Many of them had hypertension they didn't know. Some of them had diabetes they didn't know. So I would say that a lot of the time, if we could create programs that are more focused to men, and probably get some timings that are more favorable to men. And some people also say that some of these programs seem to be more geared towards the female who does the cooking, who does the grocery. If there's a way that these can be refashioned a bit to suit men who don't actually do that, and if they can even bring their partners into these programs who actually involved in these the cooking aspects of the house, and outside of that, even physical activity, making sure that this is a big part of these programs, because a lot of it is heavy on diet, which is important regardless, but the physical activity aspect, is equally very important, especially for men, because it does, for men, it's much easier for them to lose visceral fat when they're more physically active compared to females. So yes, these are a few of the things that I will be wanting to discuss, or I will be suggesting. Yeah.
Sure. And I think it's really important that we never forget the impact. I mean, that anecdote that you said, it really described it. That stigma that unfortunately can surround this issue, or some of these issues. And stigma, as we know, can lead to mental ill health, if I can put it like that, or diabetes distress, as it's sometimes called, as well. So you spoke about the stigma, the sort of embarrassment that can sometimes be around some of the subjects associated with cardiovascular health. When we're talking about diabetes health, we're talking about cardiovascular health as well. And what would you say are the sort of main aspects to the mental health distress, the diabetes distress that men can experience? We've spoken quite a bit about the sexual health, and we'll carry on speaking about that because we've had lots of questions about it. And just to remind everybody to do stay as active as you can in the chat, ask lots of questions. We've had lots of questions about sexual health in relation to diabetes, in relation to men. So tell me what you think about the mental ill health, the mental distress that men can experience compared to maybe for women.
Yeah, thank you. Thank you for that, John. Mental health is difficult to discuss, especially in African men, I must say. This is something that, as you said, is a big stigma, and is huge, and we have to be able to debunk it as much as we can. And there's no one approach to this thing. First of all, in general, not just in African men, mental health is something that is looked at as some form of weakness in men. It's not normalized as much as it is in females, and I struggle to wonder why. And we as healthcare professionals, and even from policy, from the government level, have to be able to speak more freely about mental health and how it does impact both men and females equally. I guess because females potentially are more able to open up and discuss issues around their emotions and around their mental health, But men are looked at as, oh, they have to be tough. You don't show your vulnerability. You don't show your softness, and that just causes a lot of, will I say, years or months of, this problem getting worse. Mental health and diabetes is a big thing. We talk about diabetes distress. We talk about diabetes depression. We living with a chronic illness like diabetes every day. Some people will think, oh, they have, it's their fault. Oh, it's because they're too big. Oh, because they probably think that, oh, they're not responsible enough or disciplined enough to be able to manage the condition. But no, it is a condition like any other condition someone can have. And there's help. You can get treatment, you can get support. But if you don't talk about it, how will you be able to address it?
Absolutely. And as you said, took that one person to express what they were experiencing, what they were feeling, for the whole group to open up. So on the one hand, the person themselves needs to talk about it, but we as healthcare professionals, we also need to talk about it with people, so we together normalise it. I think that's one of the ways that we can do better. Any other tips that you have about how we can do better?
So, as you rightly said, healthcare professionals, we can do better in actually eliciting and talking about this. I have a strategy in my clinic that I use. I call it, well, it was coined or was formulated by a professor in my region who's an endocrinologist, who I think very highly of, Professor Vinod Patel. So he coined or he formulated an alphabetic strategy to use when you are in a consultation room in a diabetes clinic setup. So it's A to G, but I've added a H to it. So A just talks about advice about physical activity. So just make sure you're addressing all the important things. B is the blood pressure, and C is the cholesterol, and D is the diabetes itself, and what medications or changes the patient, the person living with diabetes has to make. And E, we talk about the eyes, retinal screening. You need to go get your eyes checked regularly. And F is the foot. Make sure you check the foot to make sure all that's fine. And the G, we talk about the guardian drugs. What are the medications will support this patient in terms of cardiovascular risk, like statins or ACE inhibitors. But the H, which I put myself, is the holistic care, which I then start to think about mental health. Okay, so I'm addressing this individual. I've spoken about all these other things, their cardiovascular risk, and I forgot to say G. Part of G is genitourinary, which just makes me to talk about erectile dysfunction, because it's all part of that aspect. But the H, which most healthcare professionals forget. I know, yes, time is very short in our consultations, and that's why these kind of strategies are fine, to quickly go through them. And I found that when I get to the H, I need more time. And then you could bring them back if you can't finish. And that's when, if you actually ask the individual, how about your mental health? How could we, is there an issue with that? How are you managing this condition, and how has it actually affected your mental health? And then it opens a whole lot of discussion.
Thanks very much. And we keep saying about erectile health, so it's the G and the H actually from your list, I think. So genitourinary, but also part of the holistic health, isn't it? So we know that men with diabetes are more likely to experience erectile dysfunction, difficulty obtaining or maintaining an erection for those who don't understand erectile dysfunction. So that is a particular issue that men living with diabetes can experience, and very impactful, as you said earlier on. And would you like to say a little bit about how we can assist people with this?
I think first and foremost is actually recognizing and letting them be aware that diabetes has a very big impact on their, should I say, performance in the bedroom, or in terms of maintaining or actually gaining or sustaining an erection. Because diabetes affects that aspect in three big ways. You need good blood flow to the penis to have or maintain an erection. Now, if there are lots of disruptions to that blood flow, which we get in people living with diabetes if it's not well managed, because it's more like when you get all these clogs in the pipes of the plumbing pipes, and because of the high blood sugar, the vessels are clogged up. They can't, and blood flow cannot get to that area. And again, the hormones. We know that, of course, if you have high blood glucose, even your testosterone level, which is needed to maintain an erection, is lowered. And again, the nerves. We know that blood glucose does affect the nerves. So educating them about it, ensuring that you actually support, because they're medications. Viagra is one of the medications I tend to give for my patients, and that does help, but also spurs them up to actually say, look, I need to get these things sorted out, especially other things like their blood pressure and their cholesterol, which also can contribute to the erectile dysfunction. So very important, I think, educating them, most importantly, letting them see how it actually affects them, and then giving them that, should I say, that charge or that booster. Look, I'm going to do something. I'm going to get into the kitchen more and make sure that I eat what I'm supposed to be eating, or I cook what I'm supposed to eat, or help whoever's doing the cooking do it. I'm going to exercise more, because that will help that. And it's one of those parts of my consultation that, it brightens them up. They just, you could see the change that, oh, how does this guy know? And then they even want to converse more. And when you bring them to the next clinic, before you even get to that aspect, they're talking about it already. Like, oh, doctor, that thing worked. Oh, I could see improvements. Oh, and I can tell them that, yes, that's because your levels are coming down. Your weight is coming down. Your blood pressure is improving. And of course, they have that confidence again, which the medication sometimes you give them can help to boost. Viagra is what I'm talking about. Yeah, thank you.
Well, many of the medications of that class that can help to with erectile difficulties. And I think one of the things is that want to normalise that conversation. So if somebody doesn't bring it up with you, and knowing that as a healthcare professional that this is quite common for men to experience, we ask that question and we normalise it by asking it each time. So then it doesn't become a big thing. And then some people don't actually realise that help is available. So what sort of final tips would you like to give us, Ray, in terms of optimising men's health? You've said get into the kitchen, do what you can to be as healthy as you can in terms of lifestyle, in terms of your physical activity, in terms of the cooking. I think we should add in the shopping there as well. But get involved in your health and be as much as you can, optimize what you can for your health. What other final tips would you give us?
I think very important from a men's perspective is they need to be able to discuss some of these things more freely and normalize the discussions around this aspect of mental health, especially. I think that's a big one for me. And even erectile dysfunction, so those two, speak up. Even if the healthcare professional doesn't bring it up, be bold enough to talk about it. Because not giving excuses for my colleagues, but maybe because of time pressures, and we know how NHS is overstretched and all. You bring that conversation. It's your consultation. You need to own it. And we all as healthcare professionals know that we have to individualize our consultations to the person. It is not our agenda, but your agenda. So bring your agenda to the table. If it's about your medical health, speak up, we will help. If it's about erectile dysfunction, speak up. There is help out there.
Thank you so much, Ray. Thank you. Really appreciate it.
Thank you, Joan, and thanks for having me.